Thank you very much for joining again, Karsten. We said we were going to get together
my
again.
pleasure.
That's very good of you. So today, I think it would be useful to discuss some bone pathologies, which often isn't one of the main talking points. But I know from the people that I work with in the UK, we're seeing more and more opportunities to treat things like shin splints, as more and more of us have got focused Shockwave. And we'll talk about that because a lot of the listeners don't have focus. So they always ask the question, can I use radial for this condition, that condition, etc. So if we can, I think the best thing to start off with is shin splints or medial tibial stress syndrome, because they're the most common ones we see in the UK as physiotherapists and osteopaths. So could you just start off, I guess, for those people that don't know, just discuss some of the mechanisms behind, or the postulated mechanisms behind how it affects bone?
Yeah, so it appears that certain, let's say, age groups or population groups are more prone to suffer shin splints or medial tibial distress syndromes than others. So there are some clinical studies from military personnel. As soon as they enter mandatory military service with age 18 or 20, and they have to march or walk quite some distance, 15, 20 kilometers with some backpacks, some 30 kilo backpacks, there is a very high rate of shin splints. And actually the largest study I am aware of in shockwaves, focused shockwaves in shin splints has been done in Colombia in military personnel. And I reviewed it some years ago. So it is quite often.
Is this the Garcia one in 2000? I think I found this, you reviewed this 2017, I think it was.
Yeah, right, can be, yeah, right.
I'll post it on the end of the podcast as an attachment.
Yeah. So actually, military personnel is of risk. On the other hand, running exercises or every sport where running itself play a major role might prone to develop shin splints. And I myself did an analysis in 2008 in running athletes which were 300 running athletes running some 60 kilometers every week. And the most frequent overuse injury were Achilles tendon, then came patellar tendon, third was plantar fasciitis, and fourth was shin splint. So in that cohort with some 60 kilometers or 6 hours in a week running, it is quite frequent. And I have some athletics personnel who, especially if it turns season-wise from indoor to outdoor in March, April, for example, and the change of the surface leads to a higher likelihood of shin splints. So it appears that even surface and for sure shoe work will play a role in this regard, and the number of steps and the mileage and so on. So
sure.
This is at least what I know in the moment.
Okay, and when talking about, just summarize if you can some of the mechanisms that are thought to help when you place shockwave upon a bone. What are because we know a little bit about how it works with tendons. We know more than we do about bone, I think, certainly from what I've read. So what are the postulated mechanisms by which you think that helps healing in bone?
So actually, if it comes to shin splints, it appears that it is not only a bone problem where you might see an MRI, some bone edema, but oftentimes you see some periostitis. So some, let's say, inflammation around the bone, in the chest of the bone, for example, and maybe even in the adjacent tendon. So tibialis anterior tendon might be deteriorated or inflamed as well. So I would put shin splint as a combined injury, overuse injury of the bone and the surrounding tissue, say tendon and periosteal sheath. And there is an inflammation. And it appears that on bone, and we will talk later on shockwaves in bone and the history on bones, but it appears that there are some beneficial effects, especially when you consider focused shockwave, because you have to have high energy apparently in the moment to get a bony cell reaction. So we are aware that osteoblasts who or which encourage the or build up the bone are stimulated. There might be even some interaction with osteoclasts. There are some beneficial effects on cytokines, bone morphogenic protein, and so on. So some growth factors, bone-wise, are stimulated in a kinetic fashion by shockwaves. And there might even be effects on so-called gap junctions, which are tiny channels within the cell membrane. And these gap junctions coordinate communication in between cells, so bone cells, in that way. And it appears that focused shockwave can somehow be beneficial in the interplay of these gap junctions and connexin channels. So there are, at least in my view, multiple potential effects which support or underpin the beneficial role of focused shockwave in bony disorders, let's put it this way.
Okay. And so are we really, as I hinted at the start, are we really talking about focused shockwave because of the energy it can produce, in essence, for bone pathology, whether it be stress fractures to non-unions? Do you know of anything where radial has been used where it gets at least some evidence, or is it really just not going to be producing the energy we need?
So in the moment, I am aware of a single, I think, cohort study from Southern America, I think from Brazil, where they did pseudarthrosis of long bones. I think it was tibia with radial shockwaves. And this is the only single report I'm aware of with a sample size larger than 5, also besides case studies. Yeah. And on the other hand, we have some 35 years of experience of using focused shockwaves on bones beneficially. So if you only take the number of publications, I would say there is the overwhelming vast majority of papers dealing with bone problems in study conditions are using focused shockwave. And we have only one cohort study, not controlled, no randomization, not so on, from a single country in Brazil. Yeah. So I would say from that point of time, we have solid evidence for focused shockwave, and we have nil to nothing, some anecdotal, I would say, on potential application with radial. However, as of now, and it's what we say in our German Shockwave Society and on bones, you have to have high energetics, meaning higher than 0.25 millijoule, speaking of focused shockwave. Okay. So that's what we know now in the year 2020. It might be different in 5-10 years time, when there might be much more studies, well organized randomized trial, maybe comparing radial and focused shockwave, same frequency, same energy levels. It might be that they might be even working. However, as of now, we only can say it for sure for focused shockwave.
Okay. And if you, from your point of view, when you're treating someone with shin splints, and we talked about the energy levels there, what is your average that you would see the patient for in terms of sessions? Because we know with tendinopathies, as we're always talking about 3 to 6 sessions. Do you get them in once a week for 3-4 sessions? And how many shocks do you apply over that area?
So usually I see patient, or I estimate that I do 3 to 5 sessions focused shockwave. I usually do it once a week, maybe every second week, depends on scheduling of patient and so on, and on training level and so on. Yeah. And I usually do 2,000 shots per leg if it's both legs, so 2,000 shots for both legs. and I start slow and low. So on a, let's say, very, very nano energetic level, 0.01, 0.02, I start in the area where I marked beforehand on the shin splint where the location is, and I go over the medial side and get or elevate my energy until patient feels something. Okay. And then I try to get the idea where the epicenter of the pain is in this given patient. And then I play around and increase pain driven by the patient, my energy levels. And sometimes if it's very active and very painful, it might be that I can only apply nano energetic 0.03, 0.05 millijoule. On the other hand, it might be that I can go up to medium energetic 0.1, 0.15 millijoule, but very rarely I do high energetics in shin splints only, which is, in my view, one argument, just as an observation, that not only the bone, but also the adjacent tissue, say periosteum, say tendons, play a role where we might have lower energy levels to get a positive reaction. You know, that's what I'm observing in the moment. So I'm mainly doing low to medium energetic focus shockwave, and I combine it usually with radial in the same session. And it might be that even with low energy, with a large applicator, for example, with D35, which means 35 diameter steel applicator, and only 0.5 or 1 bar with 8 hertz, so slow and low, I do it in combination, you know. And if it's a case where it's very, very painful, I might even start with radial with 0.5 bars, but with the Atlas, just for a pre-treatment to get some pain reaction, and then I might jump in. So it really depends on patient.
Okay.
But usually 3 to 5 sessions, 2,000 shots at least. I would not go higher than 4,000 shots on a single bone, usually, because it appears from, at least from animal data, that the higher the number, so there is no linear relationship. So the more shots, the better result, but it's more bell-shaped. So it might be that in bones, it's in between 2,000 to 4,000. And then if you further increase 6,000, 8,000, you will have less efficacy. Okay. So that's why I limit it somehow on the number of shots.
Sure. And I'm assuming that you with our focus device, you use a standoff, the large standoff with that, obviously.
Standoff 2.
Like that. Okay. Yeah.
Right.
I don't know whether, I mean, you've covered everything on the concept of shin splints there. I mean, should we move on to, I guess, the middle ground, which is stress fractures?
I would say, just as a future outlook, I would say that as I'm aware, the EMTT, the magnetolith machine, is available in the UK already, and there are some avid users already in the
I might be one of the
United Kingdom. I'm aware of. So and I combine focus and radio shockwave with the EMTT in my shin splint patients. And I see a more rapid recovery and less frequent visits if I combine it simultaneously. So I start usually with focus, then radial, and then do some 3,000 shots at least per leg with the magnetolith. And depending on the architecture of the patient, I might even put the ring around the leg, depending on ankle mobility. Or sometimes if it's bilateral, you might place it in between. So, and I think in these patients, they benefit even more from the combination than from doing it alone.
Okay. All right.
As an outlook, you know?
Yeah, sure. Yeah. Okay. And so moving on to stress fractures, which we see less of, but we do see, and you know, certainly at the moment with COVID, with the concept that not everyone's getting X-rays and MRIs and so forth, they're usually just told to go back to their physio. So I've seen certainly a few more of those through lockdown because people are doing more walking and running and so forth. And I think it comes back to this question, which is ever more the conversation with Shockwave, which was 6 or 7 years ago, Shockwave was just for recalcitrant, difficult to treat conditions that have to be chronic before you use Shockwave. And now we're seeing more evidence where we're starting to intervene in acute cases, because we see that there's evidence now for enhanced healing rather than just changing the nature of what's happening in the tissue. Do you see a place for Shockwave now as an early intervention for when they get shin splints straight away and you're straight in, and stress fractures where you think there might be a stress fracture here, I'm just going to start treating it anyway because it's only going to enhance? Are you starting to use it more like that?
I would say there are different, let's say, perceptions. On the one hand, how, for example, the ISMST and others got the recommendation was based on published evidence. Mm-hmm. So if in a given, let's say, study, for example, pseudarthrosis or non-union patient, which is at least 6 months of non-healing, are included, and the result is positive, it is delineated only for this cohort, which means 6 months. In tendons, the very same thing. So usually for Achilles tendon, for example, patients in this trial which have been published had at least 3 months of tendon problems, and then they could be included. So therefore, the evidence derived from the study is only for chronic patients. And we have only really a tiny number of papers which included acute patients. That's why we do not have that much of solid evidence. And I did not know, did not touch by numbers, but I would say at least, 90–95% of all papers deal with more chronic conditions, and maybe 5% acute, so less than 3 months. That's what reality is in the moment.
Sure.
On the other hand, from a mechanistical point of view, if we start with the bone, if a bone which did not heal for 6 months receives shockwaves and heals with a 4 out of 5 chance, so with an 80% chance in pseudarthrosis, in non-unions which have been established for 6 months, why not? Mm-hmm. Should a bone benefit if it's not healing for 3 months, not for 6, for 3 months, by the very same, in maybe even less energy or even less sessions, maybe. And then a step further, if we have a patient with an acute fresh fracture, it might be that if you do shockwaves early enough, you might even enhance or accelerate healing in that very patient. And I'm in the moment only aware, and I will show it in a second, of one single patient or one single paper. I'm not sure whether or not, are you seeing this paper in the moment?
Got that. Yeah.
So it is published in the year 2009 from Italy, from Bari, with Biagio Moretti and Angela Nutanarcoli, which very smart people in Shockwave. Mm-hmm. And I will show you in a second, they included 204 cases through arthrosis, did shockwaves, fine. They did 16 cases of fresh closed fractures of the tibia, fresh. And they applied focused shockwave with the Storz device at that point of time. And I will highlight this in fresh fractures in these 16 cases. The shockwave was done 1 month after external fixation and with 0.07 up to 0.17 millijoules, so low to medium energetic. And they could show an acceleration of healing in fresh fractures. And they propose that maybe an interaction with NO, with nitro oxide, might play a role in the beneficial healing in fresh fractures with lower energy. And this is, for me, my only paper I'm aware of which dealt with acute or fresh fractures, which has been published in the moment. So this is This is what we know from science. So yeah, there might be, but on the other hand, I would say perspective. If we are avid Shockwave users, we want to provide the best evidence and the best treatment for your patient. Sure.
Yeah.
Ensure everybody will agree that we want to have the most or the fastest healing possible in every patient.
Yeah.
Sure. However, from a rational point of view, a fresh fracture of the radius, which is done maybe conservatively in a patient who has no risk factors like diabetes, like smoking, whatever, it will heal within 6 weeks with a plaster nonetheless. So there is not the place or not the argument that if a patient wears it 6 weeks or 5 weeks, where's the argument, where's the benefit? And from an insurance point of view, I would fully agree that there is no argument.
Yeah.
You know,
yeah.
The only cohort where I would support early shockwave therapy for bony acceleration are high or highest level athletes, for example, in soccer. And we are aware that on a Champions League level, even in the year 2014, 1 day off on Champions League is 20,000 euro. Right. 1 day. So if it heals 1 week faster, it is 140,000 euros, you know? Yeah. And only in that perspective, in these high-level athletes where every participation in a game is very, very costly, then it is okay. But even if I say I'm doing it in a marathon runner, who runs or who wins New York City Marathon, even in this case, I would not support in the moment preventively to use it in an acute fracture, because usually it will heal, you know?
Yeah.
That's the perspective. So, because people are using machines, machine, and you know, one has to find the fine line where it is getting to over treatment.
Yes, I completely agree. And as well, we have to, now it's becoming more common, and it's a part of the conversation. I treat some motocross riders, professional motocross riders. And once you tend to get in with one or two of them, and they then tell their friends, you must go see this guy. He's got all the best kit and equipment. And they always break stuff. And they just come along, sit in my room, and they've only broken it 2-3 weeks. And they almost want you to do it. And I think we're seeing more of that, where patients are now, a lot more information's out there. Oh, could you just not shockwave it? It will speed it up. And it's, of course you want to do it you can to help them, but you need, like you say, you need to make those decisions based upon the evidence.
In your
money as well.
In your motocross riders, I would say, and I did when I was still in Hanover Medical School some 15 years ago, I had a cohort of, series of motocross riders suffering scaphoid fractures when landing on the bike. So I would make the case that in these special cohort and on locations, so location-wise in a scaphoid where we know it is prone for pseudarthrosis, and if you have a A-type scaphoid fracture, which is by definition healing with a plaster only, with no operation, in this very patient, if it's a motor cross cyclist, I would say, okay, one could argue the risk for pseudarthrosis is very, very high, and we have a non-union risk. Under this circumstance, I would advocate that it might be a good idea to do it, you know. But I would say usually nature is quite smart in healing, and usually it does not need on every single second our external help, even if I have marvelous magical machines. You know? But nature is even smarter.
Yeah. Good point. So as we've moved on to naturally there to pseudoarthrosis, the mechanisms you sort of touched upon earlier, and would you say, rather like we have with tendinopathies with fracture healing, we know that lower extremity tendinopathies tend to respond better in the literature than upper extremity. So I would rather treat an Achilles and a plantar fasciitis rather than a tennis elbow. The evidence is just a bit more compelling. And do you see what would be your take on certain parts of the body in terms of pseudoarthrosis? You mentioned scaphoid there, but we see a lot of, the tibia non-union is the more common. Do you see a difference in outcome in terms of bone pathology?
So actually, Wolfi Schaden, who is the, let's say, president of ISMST and is in the moment, I believe, the person alive with the most experience in treating shockwaves to arthrosis patients. And he started in more than 2 decades ago and did a thorough analysis of all of his cases. So he can say location-wise, my long bone on the humerus has a success rate with my electrohydraulic focus machine of, say, 70%. The scaphoid has some 65%. The metatarsal has some whatever percent. Overall, he says, he sees a 80% success rate in non-unions. But it's not only location, it is patient factors, it is age of the patient, it is smoking or not, it is plaster or not, it is time of non-union. So there are differences if non-union is only 6 months or 1 year or 2 years. But so the longer the established union is evident, the poorer the results. And then there are even changes or differences in atrophic, hypertrophic, and so on, pseudoarthrosis. So it is, sure, location-wise different. And for example, I believe that the worst results are actually on the scaphoid, and
the worst result,
there is not that much on the humerus. So I looked in what I found, and even in this very book from 2000, from Wolfi Schaden, the very first experience, because there is not that much evidence. And I looked just on long bones of the humerus because I did some cases on this and want to get the idea. And it appears that they only had a 40 to 50% consolidation rate. Right. So it appears that the humerus is poor. And, and I'm preparing a case where I did shockwaves and the EMTT, where we succeeded within 3 treatments. After 9 months of non-union. So therefore, location-wise, there are differences, but I would not say the upper extremity is always worse than the lower. It really depends on location and on the numbers of publications. And for example, the epicondylitis, we have some 120, 130 trials on shockwaves, and there is not that much and shoulder, we have 200. So, and I would not fully agree that the outcomes are much more better on the lower extremity than the upper extremity, but it really needs to, or you have to have a precise diagnosis. So it plays a role, patient age, calcifying tendinitis or not, degree of calcifying tendinitis, degree of inflammation, onset or duration of pain really matters quite so much on success rate. So there are differences if you only have 4 weeks, 8 weeks, or 12 weeks of symptoms before your shockwave. So this will influence your outcome quite significantly. So therefore, there are much more factors than only location, I would say.
Okay. In this country, which I know we've talked about before as well, there's a difference in terms of the NHS funding and the orthopedic world accepting shockwave in our country. We seem to be a little behind Europeans, particularly Germans. And when I have discussed some non-union treatment with a couple of orthopedic surgeons where I live, it's instantly, this guy needs to just be operated again, and that's just what it is, right? Is there still a sort of split in Germany and Europe about whether you are absolutely going to try shockwave first or you're going to go straight to operative intervention? It strikes me as always with shockwave that why the argument against it is so poor, because why would you not try a non-invasive approach first for 3 weeks before you try anything else, right? And when my last example of this was where the surgeon actually came back to me and said, well, it's nearly 9 months, and at 9 months he can get insurance funding for an Exogen device, which is ultrasound, low energy ultrasound, which they wear all day, pretty much like some cumbersome thing on their leg. And then I tried to have a conversation about sound waves and there being some commonality there, and I didn't get anywhere. It just wanted to operate again. I mean, is that just a failure of our country to really take on focused shockwave at the moment, or is this a problem across the world where you still have this sort of split between those that want to operate and those that want to try something else?
I think, as usual, and it's universal, that good times take time. And this is the case. And if you only look on the, let's say, on the culture randomized controlled trial on tibia and on unions, where they did operation or shockwaves, and they had similar complications, similar healing rates and less complications in the shockwave non-invasive group. No wonder, However, it is, you have to read it and you have to be open and acknowledge evidence. And what I see in Germany in the moment is, even from the orthopedic, trauma, union, whatever, journals and so on, that in the last 2-3 years, there is much more of an awareness that there is something else than the nail, an awareness, I would say, not an acknowledgement, awareness, and there are papers now, reviews, even in German trauma journals and so on, focusing on non-invasive ways for bone stimulation with lipos, as you mentioned, the ultrasound machine, and even shockwaves, and even pulse magnetic fields. So there are the three, or I would say from a surgeon point of view, as I'm a trained surgeon, there is something beyond your OR, some techniques, some machines which might help your patients without you being in the OR and without any risk. And especially if you put it in the COVID perspective, where, let's say, this is a totally planned or scheduled operation, a pseudarthrosis repair. This is not an urgent thing, so no emergency. So it will not, or a patient will not be operated in the moment in COVID times because of a non-union, no chance. So even in this perspective, it might becomes compelling that a non-invasive way to help bones to heal in 4 out of 5 cases, if you do it appropriately with the correct machine, with the correct parameters, you have a 4 out of 5 chance to have a good result. This is quite good, so they have to acknowledge, but it really takes time. And even, it's more than 20, the German Shockwave Society is 25 this year. So we are speaking the mouth all the time, again and again and again. And even after 25 years, it is not that easy. And even we have 10,000 machines, shockwave machines in Germany, 10,000,
Focused,
it is not
focused devices?
Combined. We don't know.
Okay. Yeah.
For separation, but mainly focused, sure. Because, focus are from the beginning, and radial came 99 and 2000. Yeah. So, mainly, I would say 70% most likely, or 65% is focused. So even then, even in the heaven of shockwaves, which is Germany, from that perspective, inventors, numbers of machines, society, and so on, even then it's hard,
Sure, okay.
So it is not a UK problem, I would say. It is worldwide, and it takes really time to, and sincere and good data, and a sincere approach to these patients or to these doctors or to surgeons. And I would say, in the moment they acknowledge that shockwaves even might be in combination with operation, so there's no this or the other, but the combination, or there is just another avenue to take, or to combine this. Otherwise, it is more it's more offending, I would say, if you are a steel surgeon. And if you come around with a shockwave machine, it might be somehow offending for you, because you say, okay, what is my purpose, my life purpose, then. So that's how I see it. It really takes time, and you cannot, you cannot convince everybody, that's for sure.
Okay. I think, looking at my bit of paper over here that I have as a pointer, that I think we've covered most points today. Have you got anything that you would like to cover in terms of bone pathologies that we haven't? Have you got some interesting slides that you can impress us all with? Because you always love a slide.
Oh, I can, yeah, wait a sec. I will have a look on what I have. Yeah, I will show something which I just got to know by chance. So as you might have heard, that Shockwave started in Germany, in Munich, in urology on 1980, so 40 years ago.
Yeah.
And it was an electrohydraulic focused machine. And this was published in the British Lancet on my 7th birthday, actually, on December 13, 1980. What I learned last week by chance, because I watched the video which Wolfgang Schaden prepared for the 20th anniversary of the Colombian Shockwave Society, OCC, which will be broadcasted in 2 weeks. Mm-hmm. That the observation from a urologist that shockwaves could help bones was done by Gerald Haupt in 1986, who was a urologist in Bochum, and he found not if you have a kidney stone in the kidney, but if the stone is within the duct in the ureter or within the bladder. They did shockwaves at that time, and in the moment you had a ureter or a bladder stone, the shockwave traveled through the pelvis, and they acknowledged a thickening of the pelvis. And this was the first observation that the shockwave, the electrohydraulic shockwave, might do something not only on the kidney stone or on the bladder stone, but also on the bone. And then 11 years later, this very gentleman, I will show you in a second, actually did his PhD thesis, and in his PhD thesis, he invented radial shockwaves. So as an, let's say, development step from focused shockwave with tiny or smaller devices, they did first the LITO class, which is, you see here. Yeah. And they tried to ballistically hit kidney stones. And that at that point of time, interestingly, it's only in German, this PhD thesis, but this is from his PhD thesis. He even did some bone treatments at that point with ballistic radial later shockwave therapy on teeth and on different locations. So this very same Gerald Haupt,
did you just say
observation? He is so deeply, and this is by chance. I didn't know since a week, you know.
Karsten, is that what I'm looking at? I think I'm looking at. He used ballistic radial shockwave on teeth. Yeah.
This machine, yeah, right. This is the so-called, at that point of time, because it was EMS, the LITO class. And the LITO class was the first machine to offer in the very beginning ballistic, as radial was first named ballistic pressure waves, you know, because it's only a projectile hitting back and forth. And, you know, and this was published in 97, and actually EMS came out on 98 and Storz in 99 with radio shockwave devices. And this, for example, was the very first radio shockwave device, just to give you an idea from Storz. That's how it started. So just to get the idea how things oftentimes by chance develop. So a urologist observed an iliac bone thickening and said there might be something, so let's look in.
Oh, interesting.
Yes.
And the drive for that was just to make a machine that was smaller and obviously a lot cheaper that we could use as...
Cheaper.
Yeah, sure.
Cheaper. And I might say, okay, I will show just at the end 2 cases on the combined treatment of shockwaves and EMTT, just to give you an idea. This is a failed scaphoid fracture repair in a young consultant, and he had the first operation in 2012, the second in December last year with an iliac non-vascularized bone graft, and it did not heal again. So 2 times surgery failed. And in March, in the first lockdown of COVID, I did 3 sessions of focus shockwave and the EMTT magnetolith, because the magnetolith was installed in this practice on March 7th. So very early on, I did the treatment in this patient with a combination of focus. You see here 4,000 shots, high energetic, and the EMTT machine with 6,000 shots, 3 sessions.
Wow.
And did then a 3D scanning with some noise reduction special techniques because of his screw. And you see here his scaphoid had healed within the 3 treatments within 6 weeks. Within 6 weeks after the installation of the therapy, which did not heal beforehand for a decade, you know. And this has just been accepted for publication in the medicine journal, which will be published soon, because I yesterday saw the proofs. So it will be open access in the very near future, hopefully before Christmas, but even hopefully before December, I would say. And in that regard, because we talked a lot of bones, I see a second very nice indication is symphysitis. So if you have symphysitis with some MRI bone edema, then the application of focus shockwave and EMTT might be a very, very nice tool. So diagnosis, like in this bone edema patient, diagnosis with the MRI is key. And there is even one small study doing only EMTT, so only magnetolith treatment. And they could really, in soccer players, show a tremendous decrease of pain immediately after admin 4 or 5 sessions of EMTT. So in symphysitis, where you have oftentimes bone edema and you have to look on an MRI, but if bone edema is there, then EMTT with or without shockwave, focus shockwave, are very, very good option, because otherwise in symphysitis, patients or athletes are off for a year and a half or longer. So it is a quite devastating situation, and it appears that especially in this indication, this therapy is very, very, very nice to consider.
Okay, well that's a good point, because they are difficult to treat, aren't they? And I do get asked, so just on that note quickly, on bony edema, especially for those of us that have got radial devices and focus devices, not maybe but with EMTT. How do you think the mechanism is that you're treating, say, an osteoarthritic knee with tibial edema? How do you, because there's been some really good research on MRI proof that edema reduces within a week after treatment. What is the mechanism, do you think? Do you think that is just the pressure wave helping to create literally pressure waves through the tissue that's helping to clear, you know, in a very mechanical way, the edema? Or do you go back to a cellular response that's then somehow reducing it?
I think it is more a cellular response and an immediate response. So oftentimes if we consider, or if we speculate on mechanisms, underlying mechanisms, the timing plays a role. So when does something happen? You know, there are some effects with shockwaves immediately where we cannot say it will be gene expression, because gene express or protein expression takes at least 3-4 days, you know. So if you have an immediate pain relief, there are some interactions with substance P, CGRP, some pain receptors immediately. And I would say there is the universal idea of, I'll show you in a second, the inflammation cascade, if you will. So if we wait a sec. So here is it. If in every tissue, in a bone, in a tendon, in a muscle, if there is an injury in the very beginning, you have an inflammation with an upregulation of certain cytokines. And this is followed by reparation and 2 phases of remodeling. So this course is, let's say, a year, I would say. And there are data, or there, let's say, if you put it in a perspective of only 4 days, you see here that the early inflammation phase is mediated by a concert of different cytokines, not only one, but a concert of it in, let's say, a strong area. And there is data supporting that, I have not it here in the moment, that shockwaves somehow interfere early with the inflammation cascade. So if you say if a bone edema reduction is very, very early, in my point of view, it might be that the inflammation area, because it's an edema, there is fluid, that's why you see it on MRI, and there are fluid changes immediately. So it might be, in my view, at best, my educated guess is that in the anti-inflammatory effect of shockwaves, in that case focus shockwave, might somehow interfere with that inflammation cascade. That's what I suspect on this. So that's my guess.
All right. Super. I think that's gone on longer than the half an hour we planned, Karsten.
A bit.
A little bit. Well, you're an interesting guy.
A smidgen. A smidgen.
A smidgen. I don't know what even it is. What is it? It's gone on for probably an hour.
It's Old English. It's a very bit, a tiny bit. You can.
It's enough for a biscuit and a cup of tea.
Because once upon a time, I was a scholar in Broadstairs in the southern eastern part of England.
That's where I'm from.
In Broadstairs.
I used to teach at a foreign language school in Broadstairs, well, in Ramsgate, next door.
So I spent there 3 weeks when I was in university in a summer camp, and I was living in a very lovely family, and him was an artist, she was an artist, she was an American artist, and he was a UK artist, and they taught me we tried to get some words which are so weird that even native English UK man is deeply impressed. So a smidgen is part of this.
Proper old English term. Well, next time we meet and have a beer, you're going to have to tell me where you stayed in Broadstairs, because I know every part of it. That's amazing. That's amazing.
Oh, how small the world is.
It isn't it just? Right, well, look, on that note, I'm going to say thank you very much, and we can go and have some lunch, and I'll let you know when it's all on Apple iTunes and everything else. All right, Karsten. Thank you very much for your time.
You.
Good as ever.
It was my pleasure. Bye-bye. Stay safe and healthy. Bye-bye.
Bye-bye.